Professor Lois Choi Kain. Dr. Lois Choi Kain is a global leader in the field of personality disorders. Apart from being a psychiatrist, she also has a Master of Education qualification, and she is a brilliant teacher. You should just look at her slides. As some of you may be aware, John Gunderson is considered as the father of borderline personality disorder, and he's the one who came up with the concept of BPD. Professor Lois Choi Kain is the protege of John Gunderson, and she's carrying on his legacy and further building on it. She is the founder of Gunderson's residency and the director of Gunderson Personality Disorder Institute at McLean Hospital, and an associate professor at Harvard Medical School. Gunderson's Institute offers training and supervision in GPM and has been expanding its applications. The recent one we are looking at is the GPM for complex. She works nationally and internationally. She does lots of teaching and training and supervising, and she's a very eminent expert clinician. She's a fantastic teacher. We have been listening to her. She has published very, very widely in scientific journals, and she has published textbooks, and she has contributed to chapters. We've been very fortunate to have Lois Choi Kain supervise our program. Over to you, Lois.
I can't say enough how good it is to be here, because I've developed over the last 2 years a lot of very meaningful and rewarding relationships with the teams here. And usually when I speak at these Spectrum conferences, I just go into my basement a day maybe behind and turn on my computer to Zoom in. But I feel very fortunate to have traveled a lot further with an enormous amount of jet lag, which is real, to be here with you today. And I want to thank Savya Rao and his amazing team here at Spectrum for not only inviting me and hosting this conference and bringing so much education to develop the workforce here, but their dedication to this cause is really exemplary and inspiring. So what I'm going to talk about today is going to actually piggyback on what my dear colleague Joost has talked about this morning. Because I think in all honesty, we have done our best to revolutionize the field and change people's minds about whether or not we could be helpful to people who live with BPD. And we found out from doing these very complex procedures that it can be done. But now that we've been doing it for years, we're not sure that what we're doing is quite actually the dosage that's needed. So I think now that my colleague Joost has talked to us about kind of getting out of focus of the kind of details of these very complex and elegant psychotherapies and think more broadly about providing more widespread enhanced care. We can think about the forest through the trees. And what I'm going to talk to you about today is what I think is essentially needed for all of us to heal from the condition of borderline personality disorder by bringing them back into the fold of usual care. So it's really mind-boggling to me how marginalized the study of personality is in our field of mental health care, because personality is the basis of who we all are. It's really officially defined as the special combination of qualities in a person that makes us unique and distinctive from each other, as shown by the way we behave, feel, and think. So all of us have a personality, right? And it's what makes us lovable, but also makes us annoying, because it's what brings us into interface with the world at large. My colleague Peter Tyrer talks about the fact that actually personality difficulties is what defines the human condition. It's actually just a minority of people who have so-called healthy personalities. It's like 20%. And we should actually stigmatize them because they're in the minority and they're not the people that we watch on reality TV. There's no brilliant movies made about people with very consistent and steady personalities because they're not that interesting or distinctive. They may be very reliable. But I think the personality difficulties that we all encounter throughout our lifetime is what makes us human. Personality is, after all, like our psychological skin. It's what holds the soup of everything that defines us together. It's the barrier between the outside world and what's internal to us. It holds us in. It protects us and becomes damaged by what we all encounter in life. And we bear those scars that distinguish us. But we also heal. It's what's visible about ourselves. It's how we are known and what we see in ourselves. And just like the human skin, it's actually the largest and maybe most vital organ in the human body. But personality becomes disordered by usual human functions. It is what happens when we have an incapacity to adequately adapt to life's challenges in the process of building a meaningful life. So if you have no skin, or if your skin isn't functioning correctly, it's hard to be in the world and hold it together and be knowable to others. And then it becomes challenging to actually preserve the building blocks of our life. That is the experience of work in the world and love. So we now are moving towards a broader definition of personality disorder, that it has two aspects that of course transact. That is problems of self-functioning, that is self-definition, self-regulation, self-direction, and self-esteem. These are things we all work on over time to increase our stability throughout our lifetime. Personality functioning, on the other hand, also has to do with our ways of managing our relationships. That is, our capacity for understanding other people, which we have to do in the increasingly diverse world we live in. And we also, in that diverse world, have to learn how to be close to others and be vulnerable around them. That's the part of relating that has to do with intimacy. So now we have to think about how we all have these problems of managing our personality throughout our lifetime, and that's always challenged by the stressful things we encounter in the world. Now, borderline personality disorder defines something about the extremity of the human condition. What makes it hard to be in the world is captured in this diagnosis. And a lot of people have really worried that the nomenclature has been problematic, but really it's the stigma. Because the nomenclature actually captures exactly what it means to have borderline personality disorder. Because being on the borderline means that you're between two worlds, two distinct conditions. And when borderline personality disorder was first mentioned in the literature in 1938, a psychoanalyst named Adolf Stern said that the borderline group of patients were distinct from those who had psychotic problems and those who had psychoneurotic problems. So they weren't actually the same as people who had thought disorders that were very difficult to relate to. And they were also, though, very severely mentally ill. But while they could adapt to certain parts of the social world, they had easier breakdowns and negative therapeutic reactions, and a lot of what he called psychic bleeding, being in pain. So the problem of this condition is that what it embodies is not only something that is kind of poorly defined in the scope of the things that we're more comfortable with in the world. That is the problem of making something more manageable because it's mentionable. But it's also a condition of people just barely belonging to a group in a way that provides some acceptance and security. And that's the bigger picture we have to keep in mind to improve the status of people who have BPD. Now, of course, this disorder was systematized over time in a way that I think increased its legitimacy. John Gunderson and a number of his colleagues really endeavored to systematize the diagnosability of this diagnosis based on empirical work. And they came up with this set of diagnostic features that define the 4 sectors of psychopathology that start with interpersonal problems, the problem of not being able to be alone, so making desperate efforts to avoid abandonment, and also, though, having difficulty in relationships where you're fluctuating between extremes of complete idealization and devaluation. And that's a bedrock of what we think is the interpersonal hypersensitivity of this condition. While the impulsive self-destructive behaviors are what bring these people with BPD into our clinical attention, these are actually the ones that end up remitting the most quickly and aren't as central to the disorder. But what is the affective instability and intensity that is usually defined by fluctuating moods to stressful situations, as well as a tendency towards uncontrollable anger. And this feeling of emptiness, that moves between different sectors of psychopathology, but it's often described as a felt feeling of emptiness inside oneself. And lastly, the cognitive part of the disorder has to do with a rootedness in reality, understanding the reality of oneself clearly in identity, and under stress, holding on to some realistic estimation of other people, not becoming paranoid, and staying grounded in a connection with experience and the world around you. That is the opposite of dissociation. So the fact that John Gunderson and others put this in the DSM was a road to a kind of accumulation of scientific knowledge that really proved this is a diagnosable entity that's distinct from others and is treatable. But beyond this set of traits and symptoms is a core problem that he defined in 1996 as being an intolerance of aloneness. That there's something about having these features that tie together around a difficulty making that transition between being in care of someone and then being out in the world on your own. And a lot of this plays out in these insecure attachments and these bids towards therapist availability. So he said in 1996, the intolerance of being alone was identified as defining features of the diagnosis, a basic developmental failure that involves an inability to cope with the separateness of their caretakers, what Winnicott had defined as transitional relatedness. And I think that's basically about staying developmentally caught between these two worlds of growing up under care and then being your own person in the larger universe of life where you really start to build your personality functioning and define who you are. So in 1996, I was actually not that far away from John, across the way in Cambridge, Massachusetts, as a senior in college, completing my degree in a very pretentious field of study called social studies there, where we were actually reviewing the massive canon of social political theory to understand how societies come together and how they become organized in a way that they're sustainable. But of course, that doesn't always work. And in that process, human problems arise. So what I was studying at the time actually had a lot to do with this condition of being on the borderline. Because after all, it was actually Sigmund Freud a long time ago as a social and political theorist who said something that became the bedrock of all these treatments that we use now. That the price of civilization, or civilization and its discontents, is the fact that when we join society, we have to give up gratification of some things for ourselves. The price of civilization is instinctual renunciation. And that process causes us a lot of psychological strain and demand. But it wasn't just him who knew something about this transition between our individual needs and the needs of the greater society that caused us such human difficulty. Historians, political philosophers, sociologists all said the same thing in different ways. Thomas Hobbes famously said, without government, life for men would be solitary, poor, nasty, brutish, and short. We need the protections of society. So that might be a rationale to give something up for ourselves. But what we gain in giving something up, what we lose in the social contract, is just kind of this unrestrained, disinhibited ability to be ourselves. But what we gain is freedom through civil liberty and a kind of idea of ownership of what we have. So we evolve through this process. And a lot of the problems we see in people who are on the margins, on the borderline of society, not just those with BPD, but more broadly, are because they're not in the fold of society. Because man is a moral being only because he lives in society. Let all social life disappear and morality will disappear with it. That's what Emile Durkheim said. So it's this body of thought that joins with what I've devoted my whole clinical career to give us a bigger picture. Because what I think we need to do is really take these lessons in from what we've learned about BPD to improve the condition of humanity at large. And what we do for that by bringing people in from the margins into the fold can solve a lot of social problems if we can bring the care of people with BPD into the fold of usual care that we might be able to mitigate better than any manualized treatment. Now we live in a different era, post-COVID, that obliterated the kind of familiar fabric of our lives and caused personality disorder and difficulty in all of us because it exposed us to this really difficult experience of being alone. And since then, there's been this loneliness epidemic that actually most people in the US, about 50%, report some level of loneliness that is a serious threat to their physical and mental health. It's an epidemic that contributes to dysfunction all across of human experience. Social unrest everywhere, community threats everywhere, social discord everywhere. And in fact, the translation of the impact of that on our individual health is vast. They've estimated that the impact of severe loneliness is equivalent to smoking 15 cigarettes a day. So these forces have all brought us into some kind of borderline condition that we can relate to and really embrace as something that we all have an interest in improving. So what I'm going to do now is talk a little bit about how I understand how these things work together to underline and emphasize or describe what the common factors are that we need to focus on in a simplified generalist care model to provide more good enough care for everyone instead of really expert care for very few. So if we return to the definition of borderline, I'm going to recast it in a different kind of schema and say that actually in this age of loneliness, people who have interpersonal hypersensitivity, that drives a lot of problems. So after COVID, who here feels like more interpersonally comfortable than they did before? Nobody. Everyone is like raw and irritable, and I've heard from my colleagues here that there's a lot of problems with road rage and things like that. I think that's actually pervasive. Actually, the return to living after COVID has been quite the adjustment. We're all interpersonally hypersensitive. And actually, that produces a lot of emotional arousal and dysregulation. So it's not useful to say which came first, chicken or the egg, but these things actually powerfully interact to produce stress and actually unseat reason in human beings, because these things amplify arousal to impair cognitive control, right? And that's what gives rise to the problem that we're so obsessionally trying to treat with these manualized psychotherapies, the self-destructive suicidal behavior, which is an epiphenomenon of these deeper problems. So this is actually a representation or a smoke signal that the person who is suffering from intense interpersonal hypersensitivity and emotional dysregulation is feeling alone. And they're not yet in the fold of feeling a place of situation or belonging. And that's where their ability to realistically make contact with others, not being paranoid, not being dissociated, not being cognitively disorganized really fails. And then nothing can contain them and define them and direct them through life. This is a position of tremendous vulnerability. So how does this unfold? This is an outcome, not a starting point. And borderline personality disorder develops over a long period of time. There is a myth that all teenagers are a bit borderline, and that's because of the developmental trajectory. That we know that when kids start to make that transitional relatedness out of the nest of direction from their carers, they actually become more emotionally sensitive, interpersonally hypersensitive, and impulsive because they don't yet have the internalized capacity to manage their social and emotional world. So all kids actually peak in their BPD symptoms around the age 8 to 14, but actually what happens is people develop a sense of self, they get a social group that gives them a sense of belonging, and then actually the application of their energies into building a life forward then starts to regulate them, give them motivation to get along, and solves a lot of these problems in their natural environment. But the problem is there is a group of people who start off with a higher loading, which is really going to challenge their ability to do the same thing. Like I said, you can't actually define yourself that well if you don't have these capacities to manage yourself reliably. So the distance they have from the peers combined with this overload of symptoms is what actually keeps them on this borderline in this condition of not being able to find a niche in the world. So these patients have this problem that persists, and those are the ones that become the patients we treat. So understanding this trajectory, I think one of the cues we can derive from this is that we do need to intervene earlier, and it's not that the symptoms are going to go away, but trying to help people with these vulnerabilities to stay in the fold of society is really probably going to generate solutions that we haven't found more stably yet. $6 billion might do the trick for getting us there. So one of the things we also know is that having BPD actually dictates stress generation forward. So we've oftentimes really focused in the world on how trauma produces BPD, and that is true. Stressful exposures do increase the risk of developing BPD because it exceeds the supply of both support and internal capacity. It obliterates personality development because of these factors of stress. But what we also know is having BPD early with the symptoms of impulsivity and negative affectivity breeds or predicts social adversity. First within the home, that these symptoms actually predict harsh parenting and lower levels of warmth in those who are closest to them very early on throughout childhood. And then that adversity socially feeds into this loneliness that becomes more likely to generate the syndrome of BPD. That was from a study in Pittsburgh that was socioeconomically representative of that locale. And it's not just in the US, because this was also replicated in the UK, where Catherine Winsper found that dysregulated behavior early on in life actually were predictors of the social adversities that we believe put people at risk. These are transactional. And then that social adversity feeds into the likelihood of developing BPD. And the detriments of this problem go on and on, because obviously BPD is going to impair a person's ability to work in their social environment. Kids are supposed to go to school and function there, but the symptoms of BPD really get in the way, and intervention is needed earlier, because then this limits life opportunities, it limits the likelihood of finishing school, developing a sense of self-esteem, having doors open for you because of the symptoms of BPD. But if people find a way to manage their symptoms and remit, they're going to have a better prognosis over time. So that's the good news. But for all people in school settings, having the features of BPD make it more likely that you're going to have trouble both on an academic level and a behavioral level, because these features of BPD, self-harm, impulsivity, and affective instability, uniquely account overall across the samples for academic achievement and social maladjustment. In adulthood, this continues to march on, and BPD traits are associated with a number of problems in the occupational realm. And people with BPD drop out of life. They stop working in a demoralized condition, not feeling like they can do it, not getting the help they need, and they're less likely to be in the world with a vocation or calling that defines their future and how they both manage themselves and interact with the world. And actually, we think that this poor occupational functioning is predominantly a reason that people fail to recover and function even when their symptoms remit. And we think that being in the world and having some constructive role in it may buffer against the worst effects of BPD. And lastly, people with BPD have restricted social networks. So social networks are the antidote to loneliness. Having a broader, stable, diverse social network actually promotes our growth forward for all of us. But having BPD increases the likelihood of conflict and rupture without repair. That's what the studies show. And it decreases a sense of support and satisfaction, providing a buffer to stress that most people need in life. Interestingly, people with BPD have more former romantic partners in their social network. So imagine if all your social network were all your ex-partners. How would that go? That would not be the most stable, reliable social network. But actually what happens here is that in the sociology literature, having just strong ties limits your capacity to learn new ideas. So what happens when you have a limited and intense social network, your capacity to change your mind gets restricted. And this limits social integration and social mobility. And ironically, I think this is intuitive, social exclusion, when you're on the margins, that actually impairs self-regulation in and of itself. Not feeling you belong somewhere will make you dysregulated, I guarantee it. And then actually self-regulation is what people need to be supported in getting to social inclusion. And the interesting thing, the process of socialization, apart from psychotherapy, is what actually gets our social brains to increase so that we develop the neurocognitive abilities that we need, that is mentalizing, to be able to kind of navigate this process. So John Gunderson was really into the idea, they don't need to talk about their inner thoughts, they need socialization. They need to know why the person they live in is really upset with them because they ate all their peanut butter. They need to know more about the social transactional process. Now, the interesting thing about BPD is that despite the severity, we know from longitudinal studies that people do achieve symptom remission, not just with DBT and MBT. This was actually big news to the world, and it doesn't mean that all patients recover. It just means that they do not meet diagnostic criteria over 10 years' time. So there's something that happens that actually has a natural course of remission from these traits. Now, how people get there is really the problem, because what I think happens is this marginalization. People with BPD retreat to the borderline of society. They go quiet. They live very limited lives, but they're just not symptomatic anymore. But that's not a solution to this problem, because we see their functional levels don't change. And this is actually the problem with these treatments that we've been using, is that we work really hard to get the symptoms down, and that in fact does increase the likelihood of being more functional, but it actually doesn't do it well enough. So this is where I think we need to focus, because actually we see on the left that most people with BPD will achieve a 2-year remission, and they'll sustain that. The recurrence after that is pretty low. It's like 30%. And if you achieve an 8-year remission, you're even more likely to maintain that stability. But still, recovery is more fragile. If you look on the right side of this graph, the 2-year recovery is about 60%, and the loss of that is about 40%. So the likelihood of recovering is there, but the likelihood of losing that recovery is also pretty high. So we need to help people recover. We need tactics to help them recover and understand that their course of recovery will necessarily be bumpy. Because having these features of BPD actually aren't just generated from trauma. Actually, there were longitudinal studies that really looked at life stress and whether they produce more symptoms along the road for people who have BPD. They did not actually find that. But what they did find is having BPD generates ongoing stressors throughout one's lifetime. They're more likely to have breakups, layoffs, etc., like we just talked about. And they're also prone to other stressors that we have no control over. Because BPD is a G factor, or general factor of vulnerability for persistent psychiatric dysfunction and low resiliency. I think that makes intuitive sense. When we have BPD patients that don't respond to treatments, they develop a number of different disorders, they never have the opportunities to socialize and gain skills they need to have a meaningful life. And that is what we're trying to treat over time with these complex cases. We still have to treat the BPD because it's treatment of these general factors that actually is the most malleable within personality. There is a big move towards dimensionalization to look at the other personality disorders, but no proof that any treatment works for those personality disorders. So we're still in this kind of borderline about what to do about dimensionalization, because actually the thing that changes most within people in terms of their personality is not their compulsivity, detachment, disinhibition, or dominance. It's this borderline factor. And with that borderline factor is the most change in other areas of functioning. We need to treat the BPD and pay attention to the treatment of BPD in order to get them more functional and have a role in the world. So what do we do with treatment? This is the short story of the fact that there are no medications that work for this. This is something that illustrates something that's common to the human condition at a severe level that has to do with how we manage our personalities: self-direction, self-esteem, self-regulation, intimacy, empathy. If there's ever a medication that is produced to treat all of those things, that person is going to Stockholm. But I think it's safe to say this is likely never to happen. But there are these treatments that my colleague Joost talked about, DBT, MBT, and TFP, that really gave us some hope that there were ways to think about this problem and organize the relationship with patients with BPD in a way that actually helped them get better. But the problem is these are very elaborated treatments, and we don't actually know what works about them. And I remember when I was first starting out, we would talk about the minutiae of these treatments, like, is this teleologic mode or is it pretend mode? Should we use this skill, mindfulness, or should we use distress tolerance? And he would actually really start to make a lot of faces because he was like, who cares? Is that really the key issue here? We're losing the forest through the trees. And what he said is we need to do something that actually maintains good clinical care rather than these kind of obsession with details that we're not even sure are the operative force of the treatments that work. So what he said is what we need to do, knowing that patients can remit over time, is facilitate the natural course by not doing anything harmful, helping people get a corrective experience of going back in the world and dispelling their own notions that they're broken beyond repair, they can't do anything well, and they can't do anything positive in the world, and also correct their expectation of others. That others are not just either heroes or demons, but they're a mix of good and bad in a way that's necessarily disappointing, but sometimes helpful. So this treatment, generalist treatment, is a lot less equipment to just try to help people manage their symptoms to get back on the road of life. The good news is, unlike medication, psychotherapy has few side effects. Maybe this one is one of them. My physical therapist says this is the worst possible position you can lie in. But I think there's something to this about the treatments we're doing for BPD, because what I've seen over time internationally across a lot of very skilled teams, including the ones here, is that we keep patients tied up in the activity of psychotherapy, trying to hammer home the things we do when we're actually not helping them be out in the world and live their life. So Joost talked about these common factors. Now this is from people who do common factors research in psychotherapy. Lambert is the author of this graph. He said that there were a lot of different factors that feed into outcome. And I think that we are familiar with these things. Placebo responses are robust, especially for those with BPD. The patient-therapist relationship, the therapeutic alliance, is a good third of the fact. And then there's a bunch of other factors. But the type of therapy, that's only 15%. It's just as much as the placebo response. And these meta-analytic studies that have been done on all the randomized control trials of these psychotherapies, of which there have been actually very few compared to treatments for other disorders, they've actually found there are very few differences between these treatments. Treatment duration, intensity, content, theoretical orientation does not produce differences in effects. But what does is just the involvement of people who are interested in treating these patients, have some skill, and have a procedure that's reliable to treat them. And even with all of that, these treatments that are quite complex, they only have small to moderate effect sizes. So if we are to actually serve the public health interests of all the people out there that have BPD, we're not going to be able to rely on brand name products like DBT or MBT, because at the end of the day, people just need something to help them out. And generic medications in the world of medicine actually constitutes about 80% of all treatment, and brand names about 20%. They do innovate, but they're not the solution to what we provide in the everyday care of patients. Andrew Chanin compared these treatments to laundry detergents. They all have different brands and fragrances and formulations. They claim to do different things, but they all wash laundry. So a lot of what we think works about these treatments, the thing that distinguishes them is really their brand. their branding, their trade dress, not their active ingredients, which really I agree with Joost. It has to do with the real relationship and helping people live their lives in a more satisfying way, which is different for every person. But what is common and central to this is just good management. These manuals help people stay in the game through the storm with reasonable alternatives within the practice of what they're doing. But what John really wanted to help people revive in the aftermath of these treatments was just good clinical judgment based on being informed about the standards of care. And that means that we can preserve the special resource of some of these treatments that still have a place in the universe for those who want it, first of all, and maybe are a good fit for it. Because there's never going to be enough of that treatment to meet the demands of the world around us in terms of treatment for BPD. And you guys are in one of the best resource countries in terms of mental health care professionals. So if all of you used a generalist treatment, you could have about 4 people on your caseload with BPD and treat them with a generalist approach, and that would meet the public health needs. I think what is happening here is that everyone's trying to do these specialist treatments, and it spreads the supply thin. In other countries, they don't fare so well. And then specialist treatments, even in the Netherlands, would be inadequate, even in a place where there's a center of excellence and there's a small country with a lot of people trained. So we can't rely on this, because not only is there an inadequate supply to meet demand, there's also a high degree of dropouts in these treatments. Even when people can access them, they won't stay in them. And there's also a high non-response rate. This was research done here in Australia, that across trials, about half the people actually didn't have a meaningful outcome. It's the people who did that actually brought the averages up to be significant. So we need to employ these common factors of a well-specified understanding of BPD, making it manageable and comprehensible, a highly structured treatment that doesn't need all this equipment. Like when they went from DBT Manual 1 to 2, it went from 40-something skills to 300. And they asked me to review that book, and I said in a diplomatic way, this revision is an encyclopedic expansion of skills. But the question is, do we need all that? We just need something that's focused, clear, and consistent that the average person can do, and the average person can take to activate a durable alliance. So all you need to know is in the next 3 slides. These are the common factors across the psychotherapies. And if you can keep your eye on this and stay informed, I think you can do a good job. So the first is that people have a combination of factors that lead to vulnerability. I started really late, so, okay. Okay, I'll try to get through it, because I was supposed to end right now, and we started 15 minutes late. Okay, okay, all right. I will rush through this. So this is what you need to know. The etiology is a combination of vulnerability factors that are inborn and adverse environment, and those things produce the BPD symptoms. They're at risk for creating the symptoms that then throughout a person's development impairs typical developmental processes that kids learn in school or in other places where they are in the fold of society. And then they get short-circuited in learning the very specific emotional and social cognitive capacities they need to grow up and function. And then that second set of detriments, having these vulnerabilities plus a lack of skills in life, contributes to an unstable, fragmented sense of self. There's no skin over all the components of oneself, and it's rather unpredictable what's going to come up when you have a bump in the road. So what these therapies do in a most simple sense is we have to just help people improve self-awareness and self-clarity by just thinking first. And then that actually produces a generic effect of all psychotherapies. When you start talking about what's going on, it enlists some top-down regulation. It processes emotion, burns off the amygdalar activity. You start thinking about what you're feeling, and that regulates people in a generic sense. And then once they're regulated and clear about what's going on, they can go back in the world and they can test their beliefs about themselves and others by just trying to do something different. And it's that interface with reality that's going to correct the elements that most influence personality functioning. Because if we can get people in the world and remoralize people by a good enough reduction of symptoms, they can rejoin society. They can learn to employ coping skills and skills to just give and get along. That's all it is. Like all the skills you need to learn in life you learned in kindergarten, they're harder for people with BPD, but we need to support them so that they can get a life and make it work. Because finding a place in the world, like I've been saying, can provide a niche or a container to promote continuity of one's internal personality, goals, and values. And identity is reinforced by the fit between these things. So what does GPM do? GPM, first of all, if you didn't know the literature, it had equivalent outcomes to DBT in the largest randomized controlled trial done in the literature so far of DBT versus something else. And now Shelley McMain, the author of this trial, did due diligence of not racing like a horse against a pig. You know, it's not like you took the Williams sisters and put them in a tennis match against someone who never played tennis before. She equalized the treatments by putting an arm called GPM that was informed by John Gunderson's clinical guide and the APA guideline and administered by people who liked working with BPD patients. And that actually eliminated the differences between DBT and GPM, even though GPM was 3 to 4 hours less time a week. So John thought this was great news, and he did a victory lap because it really teaches us that you do not know, you don't have to know DBT to actually do good clinical care for patients. But we do have to focus on their functioning because we learned through that trial that even though people did get better, they remained disabled and unemployed. So prognosis is improved by the kind of reduction of symptoms, but not by improving functioning. Because by getting people in the world, we want to teach them that depending on yourself is better than depending on the likes of a treatment system, even the best one around. So just using usual principles that you use in the care of all patients, that clinicians use in general, are embodied in GPM's 6 principles. Be active, not reactive. Support via listening, interest, selective validation. You can all do this. Focus on life outside of treatment. Don't get caught up in the interpersonal sensitivity that arises within all these treatment settings where we get very rigid and reactive ourselves. Be professional, but real. That's what Joost was talking about, and trying to be human, be yourself. That actually is very containing in and of itself if you understand the dynamics of BPD. And expect change. Andrew Chanin, again, actually had coined this phrase that people with BPD suffer from the tyranny of low expectations. That it's actually not helpful to them to expect less because that sends a signal that you don't have any confidence that things can change. But we can support them in knowing that change and being in the world is more difficult for them than for people who don't have BPD. And we make them partners in their treatment and expect accountability for making these changes with us. So in the interest of time, I think I'm going to skip this and go to the end. So all we're trying to do is simple, because if you have no other training and you don't do DBT, MBT, or anything else, the goal of GPM is to really reinstate good common sense with good clinical judgment. So its mechanisms are simple. Think first. Develop a corrective experience that helps you reconcile yourself between what could have been and what is. Understand that people are flawed and limited. And then get a life. When you can be less disappointed in the world or less kind of feeling attacked and vulnerable because people aren't doing what exactly you think you need, you can actually tolerate all these stressful, painful losses in life and stay in the game of building the very things that make personality work. Because you can sustain your self-esteem more directly through building a life through the challenges you have, living with these vulnerabilities, than through therapy itself. Because life is the best teacher and the therapist. Treatments should support people in functioning, provide a source of identity, because mastery of reality promotes self-confidence, identity, and meaning. And work structures relationships as well. It allows you an entree point to being able to interact with others in a predictable way. And that will enable us to return to what Freud said was important to just being human. Love and work are the cornerstones of humanity. And what we need to do in treatment is simple, even though it's going to be hard to actually manage and process. That we're trying to get patients to manage their symptoms and vulnerabilities well enough to achieve love and work. Treatment is a vehicle to that, not a replacement. So what we need to do is bring BPD back into the fold of the social environments we all exist in, to create a container and source of regulation outside themselves and throughout the healthcare system and beyond, so that everyone can actually take part, and not just those specialists, to do our part for the common interests of all of us. Because you don't need to be a specialist or selflessly devoted. You just need to be good enough. You need to be warm, reliable, interested, and most importantly, unintimidated. And you just need basic knowledge about care management. So thank you.